Thank you very much for the opportunity to present our collaborative study about the correlation between the skull base and orbits in unicornal craniosynostosis. This is a collaborative project between the craniofacial units at Uppsala Academic Hospital, where I work, and the Necker Hospital here in Paris. I am here as part of the European Reference Network Research Mobility Fellowship, and this project has received funding from the European Union's Horizon 2020 Research and Innovation Programme. So unicornal craniosynostosis is a type of craniosynostosis, which means that one or more of the sutures of the skull have been prematurely closed. This can either be caused by a known mutation or be a non-syndromic case. And usually it's treated with surgery within the first year of life. So unicornal craniosynostosis, or UCS in short. Thank you. As presented in this patient compared to this control. It's the third most common type of craniosynostosis, and it affects approximately 1 in 10,000 births. These patients are born with a complete fusion of one of the coronal sutures. It can be either the left or the right one, but it's twice as common to be the right one. This disease leads to deviations in growth. So on the synostotic side, or the ipsilateral side, this leads to a inhibition of growth. But on the contralateral side, you have a compensatory expansion, and which leads to what has been described as the scoliosis of the face. These patients, they present complex asymmetry, and they also present a large variability in severity. And the biggest clinical issues for these patients are their poor ophthalmic disorders, such as strabismus and anisometropia. And this has been shown in previous studies to be linked potentially to the orbital shape. So regarding this study is about the skull base and the orbits. So the symmetry that goes for the whole skull and the whole midface. But both for the skull base and the orbits, there are different patterns of deformation between the ipsi and contralateral sides, as in this patient compared to this control. In unicornal craniosynostosis, we have no standardized asymmetry or severity index. It is not known how the skull base and orbital asymmetry relate to each other, nor if the symmetry is different between the patients who had the left or right-sided disease. The aim of the study was to investigate how the orbital and skull base asymmetry is different in preoperative patients compared to controls. If the orbital or skull base asymmetry is different for right or left-sided patients, and if orbital asymmetry can be explained by the skull base asymmetry. This was a CT-based retrospective multicenter study, and we included subjects from Necker or Uppsala between the years of 2006 and 2021. The patients included had to be non-syndromic isolated unicornal craniosynostosis. This had to be confirmed by genetic panel testing. All scans were preoperative, and if there were multiple scans that had been done before the surgery, we always choose the first one. The patients were matched to healthy controls, and inclusion criteria was sufficient CT quality, but also that no other pathologies. And the indication for CT was mainly mild head trauma. The asymmetry index that we chose was the dissimilarity coefficient, and as a short explanation, I have a two-dimensional picture that explains a three-dimensional measurement, but imagine we have two shapes, and we want to see how alike they are, how large the overlap is, and we can calculate that after alignment. And the benefit of this measurement is that it measures three-dimensional symmetry, and this is different from a lot of previous studies which measures an angle or a distance between two points. This also gives an individual index, which enables comparison of asymmetry regardless of volume or age, if it's patients or if it's controls. And we did this on segmented meshes. Another benefit of the method is that there are no transformations, it's fully objective, and it's an automatic calculation. So we get a score for each patient or subject between 0 and 100%, where 0 would mean that there is total asymmetry, and 100% would mean that the symmetry is perfect. And by nature, this measurement will be larger for the orbits than for the skull bases, because the skull base is a more complex three-dimensional shape. For the orbital asymmetry, we used the Uppsala-developed semi-automatic segmentation software called OrbSeg. And for mirroring and alignment, we used centroid matching and then ICP registration, and this was made in Python. And from what we know from previous studies, we could expect the asymmetry index from the orbits to be around 95% for the healthy individuals. For the skull-based asymmetry, we used another Uppsala-developed segmentation method, and this can separate individual bones on a subvoxel level, either by following anatomical borders, such as the suture here, or you can, in your protocol, choose to have draw the borders somewhere else. So we developed a protocol to use this for the skull base. And we adapted the pipeline for mirroring, alignment, and asymmetry measurements that were used for the orbits, but to use this also for the skull base. And in short, we used for the statistical analysis where relevant, we used the t-tests and linear regression to look for the potential explanatory factors. We managed to include 129 patients and 94 matched controls. The patients had a mean age of 8 plus minus 6 months and with a range from 3 days to 2.8 years. And the controls, they had a mean age of 7 plus minus 3.5 months. And within our cohort, the right lateralization was twice as common as the left. For orbital asymmetry, we found that the patients had a mean score of 83% with a range between 74 and 92%. And the controls had a mean index of 96% that ranged from 93 to 98%. And we found that the orbital asymmetry was significantly worse for the patients. For the skull-based asymmetry, for the patients, this was 40% with a range between 26 and 55. And the controls, they had a mean score of 59%, and we found that the skull-based asymmetry was significantly higher in the patients compared to the controls. Regarding the influence of lateralization, we could not find any significant difference between left and right-sided patients, neither for the orbital asymmetry or the skull-based asymmetry. We did find the linear relationship between the orbital asymmetry on the y-axis and the skull-based asymmetry on the x-axis for the patients. And this was significantly correlated. This was the largest study investigating shape in unicornual craniosynostosis. We presented a novel method to objectively measure bony asymmetry in unicornual synostosis, which has the potential to be used as a severity index to compare other findings such as outcome in the future. We found that skull-based shape can explain part of the orbital asymmetry and that lateralization does not seem to influence asymmetry. And regarding the comparatives between patients and controls, we found that, of course, that this was a significant finding, and that was very much expected because the unicornual craniosynostosis patients are very asymmetric. We do believe that this adds to the argument that this is a relevant method to evaluate asymmetry and severity in this condition. And regarding the influence on lateralization, we couldn't find any effect using these measurements. And there are different hypotheses on why do you get non-syndromic unicornual craniosynostosis. And it's hard to answer that question because they are all born with the disease, so we don't know what happens before, and you cannot see it, for example, in ultrasound. And there is the main hypothesis would be that that it's more common on the right side because of the precision and delivery that's more common, which would cause strain on the right coronal suture rather than the left. And we believe that these results would speak in favor for that hypothesis, rather than that there would be two different diseases. It's well known that asymmetry is strongly linked to severity in this condition, and we need an objective severity index measure. We found that the correlation between the skull base and orbital asymmetry was as strong as the correlation between orbital volume and age, which is very well known to be a strong correlation. We argue that this might explain part of the poor ophthalmologic outcomes that are caused by the disease itself, but of course we cannot see anything about the influence of surgery or such, and we believe that future studies that includes follow-up CT and also outcome data could elucidate this further. This is an ongoing project, and the next part of it will investigate if the skull-base asymmetry can be explained by additional closure of skull-base sutures. Some of these patients also have a suture closure in the skull base, and we wish to quantify that. We also want to know if the skull base or orbital asymmetry worse in the patient with late or early diagnosis. The patients who are discovered very early, they usually have at least in the face, a more severe phenotype, whereas the patients who are 3 years at diagnosis, they usually are not so asymmetric. We also wish to investigate how the asymmetry change preoperatively over time, and as a start, we will use that. We'll investigate that by looking at the patient who had multiple preoperative scans. And lastly, in the end, we are interested in seeing how these findings can be related to the timing of surgery. So thank you very much.
Thank you very much for this very clear presentation. Is there any questions in the public, in the audience? Well, first, thank you for being here today. It highlights the cooperation between the French networks and the European reference network, and we are part of this network. I wanted to ask you a question about the surgery, but you already asked the questions. Do you think it may change something on the timing of the surgery? Yes, and perhaps the kind of procedure? Or
yeah, that is a very interesting question. At our center at the moment, we are, the most common way to treat this patient is frontal-orbital advancement at around 10 months of age, and that is a very invasive procedure. There are other ways to treat this condition, and for example, using distraction. So you do fewer osteotomies, you do the surgery only on one side. So, for example, and you do that surgery preferably also earlier. But there's also indication saying that if you do frontal-orbital advancement earlier, that's also beneficial. And that can be two-sided, because if it is the case that the earlier discovered patients have a more severe phenotype, maybe they also need the surgery earlier, whereas the patients who are not so skewed, they might not need it at the same time point. But I think that's and doing a comparative study, for example, how does the symmetry change if you do the distraction surgery or the frontal-orbital advancement? That's very interesting. And also, I didn't mention this, but the ophthalmologic disorders, they are more prevalent on the non-synesthetic side. And if we only do the surgery on one side, we wouldn't touch the non-synesthetic side.
And you told us about the asymmetry or left-right side, which could be influenced by the delivery side during birth, you mean?
Yeah, that is one of the hypotheses, yeah.
Because years ago, we studied the division of the nasal septum according to the presentation of the fetus, and there was no relationship. Perhaps there is one for the skull, but not for the nose. Any questions in the public? Once again, perhaps online? No, well, thank you very much.
Okay, thank you.